Rheum 101 was a natural conclusion for me. I've created short webinars, longer webinars, day courses, which are just me, and the next logical conclusion really will give some other voices to some, not necessarily controversies, but some grey areas and difficulties that are experienced by clinicians, especially in primary care. And that's where I wanted to go with this Rheum 101 conference, was primarily for musculoskeletal clinicians and those in primary care, because there's been an explosion of those kinds of posts, and it's a real challenge, especially post-COVID or during COVID, as we still are, with waiting lists and differential diagnoses and all these real challenges. So I wanted to create a conference which would speak to all of those things really, with lots of different voices, and I'm really happy with the agenda that we've put together and the topics, and hopefully everybody really enjoys it.
My name is Raj Mahapatra, and I'm here today in my capacity as chair of the National Axial Spondyloarthritis Society.
My name is Andrew Cuff. I'm a consultant physiotherapist and head of MSK for Connect Health, and my kind of area of interest largely is musculoskeletal conditions seen in the MSK space, and particularly how can we make care more personalised but also achieve better outcomes for patients.
So hi, I'm Chris Marty. I'm a first contact physiotherapist with a special interest in rheumatology. I work and live in the southwest of England, and I'm really passionate about advancing education and knowledge in rheumatology.
So I'm Becky Grimley, so I've just got a first contact physio role with Airedale Trust, so I'm here to learn a bit more about rheumatology, get all my knowledge and skills up to date, and just enjoy getting out and not doing things online anymore really.
So my name's James, I'm a first contact physio, I work for Pure Physio. There's quite a lot of us come over here today. We work in Doncaster, where my team do.
So my name's Chris, I'm an FCP at Pure Physiotherapy, but I also run a sports injuries clinic, which we're just sort of getting off the ground for the company.
Rheumatology we find sort of something we don't get taught at university, and something sometimes it's not necessarily taught even sort of postgraduately, and mainly down the orthopaedic route and sort of the MSK route really. And going into primary care is sort of this big void that we've found that we know a little bit about but not a lot. And obviously with the whole goal to try and reduce the time in which we're taking to send these patients on to the rheumatology team, it's essentially sort of realising how important it is and what a big part of our role it is.
So we wanted to create a hybrid conference because loads of the feedback over the last few years has been we miss in-person features of conferences, we miss the networking, we miss meeting people and being there and being in the same room as the speakers, and everybody's used to that historically. So we wanted to bring some of those features back, but also keep the hybrid nature so that people who didn't live in Manchester could also attend as well. We really wanted to do something to bring those two components together, and I think the way we've done it today has worked pretty well.
It's been great to be back in a room with people again. Online has been brilliant. Online has been brilliant because we've been able to communicate to huge audiences and really have some great conversations with people that way. But actually there's no feedback loop.
I mean, it's great that the hybrid model that we've got going on, because there's people who I work with who were down in Norwich, London, the southwest, and they've all been managed to come, but we've just popped over the peaks, and it's brilliant being able to be here and see everybody and just have a good chat and discuss that. Half an hour after each talk, we've got to all have a chat and discuss what we've learned. It's been great so far.
It's great to get back and just see people and see people in the flesh. That's what physios like, being around people, don't they?
Today I was speaking about the patient perspective of axial spa, but also a bit more about the work that NAS does as well within that. And when I talk about the patient perspective, I talk about my perspective as somebody with axial spa.
So I really loved Raj's talk. He was so inspiring about all his running and everything, and it's just amazing sort of just becoming more patient-centred, because not everybody needs and wants the same thing.
So I did two talks today. My first talk was on investigating axial spondyloarthritis in a primary care setting, and my second talk was on rheumatology top tips for those people in non-specialist settings and how you can pick up conditions like rheumatoid arthritis, lupus, connective tissue diseases and others.
The chat this morning was fantastic. Did just on essentially everything rheumatology. He went through AxSpa, just brilliant. And there's little nuggets here, there, and everywhere. I'll take into my clinic next week.
So my key takeaways from my two talks would be really to try and understand what conditions link together to make your clinical reasoning process. So as an example, if someone attends with tendon pain and psoriasis, how is that different to someone who attends with back pain and anterior uveitis, for example? Because those things lead you down different clinical reasoning pathways. So it's about linking up the different systems. As physiotherapists, especially, we're very used to the musculoskeletal system, but in rheumatology, we're looking at other systems being affected. Like I mentioned, the eyes, the skin, the gut and the bowels with Crohn's and colitis. But what are those components adding to your clinical reasoning process, and understanding that we need to mush those systems together to create one unifying diagnosis, or recognizing that there might be that unifying diagnosis.
For the physios out there, the one big thing, and I was asked this question at the end of my presentation, one of the big things I'd like people to take away from this is that every single person in front of you is different. And because they're different, don't assume you know the answer. Listen to what they have to say first of all, find out what motivates them. And when you find out what motivates them, then you can actually help them. If their goal is to be able to play a round of golf, find out how you can make that happen for them, rather than saying you can't play golf anymore.
My quick key takeaway is that osteoarthritis is sometimes regarded as the forgotten disease. So we've kind of taken it for granted. We assumed it was an inevitable consequence of getting older. We now know that's not the case. And because of that, there's been a real kind of paucity of both research and probably clinical focus, which means that we're kind of flying blind with what good looks like, particularly beyond the hip and the knee. So I would suggest that my takeaway is, let's think beyond the joint, think about the person, but also it's probably an area of focus, and don't take for granted that whilst it's common, it doesn't mean it's necessarily well understood.
I suppose my one top tip would be to know the basics of key pattern recognition for a few more common rheumatic diseases. So you can, in your musculoskeletal practice, think this could be inflammatory, it could be a rheumatic disease, and therefore non-musculoskeletal, and so I can appropriately follow the right pathways to referral onto rheumatology.
So Rheum 101 I think has gone really well today from a technological point of view, but also from a feedback point of view early doors, so I think we'll definitely run another one. I'm hoping that this might be down south somewhere in London for people that couldn't come to Manchester. Run a very similar format. I think it's worked really well. When it will be and where it will be, I don't know yet, but certainly today's whetted my appetite to create more of these types of events.